which allows us to take a deeper dive into relevant topics from around the county. My name is Nick Jager, and I'll be your host today. An epidemic of fatal overdose deaths due to the misuse of opioids grips our nation, and sadly, Buncombe County is no exception to this trend. To bring awareness to this issue and discuss addiction and recovery, we are honored to be speaking with Dr. Shuchin Shukla. Dr. Shukla, thank you for being here.
Thanks for having me.
Yeah. To get us started, will you share with us a little about your professional experience and specifically your work at Buncombe County?
Great, yeah. So I'm a family doc by training, and I trained in New York, from New Orleans, but I trained in New York because I wanted to learn in a big city with a big public health system. So this is the late 2000s when I moved to New York. At that time, New York has had a long history with opioids, particularly heroin, through the 70s and 80s. And there's a huge infrastructure there around methadone clinics and buprenorphine more recently. So my work there, besides just being a family doc, was more focused on HIV and hepatitis C. A lot of that, especially in the Bronx where I worked, was infections transmitted through injection drug use. So I got more and more exposure to that population, but wasn't really treating the addiction straight up. I moved to Buncombe in 2017. And once I got here, working at one of the FQHCs, the Federally Qualified Health Centers in town, it quickly became apparent that this is the local crisis, that opioids and addiction and overdose were really, for many years, have been devastating the communities in Western North Carolina. And so I was asked to lead some initiatives. And that's really when I started focusing more of my attention less on the HIV and hepatitis C and just general medical issues and more on addiction. So since then, I've had different roles at different organizations leading grants and projects around addiction, around criminal justice system interventions, around post-overdose response teams. And then most recently, I work at one of the two state-funded addiction hospitals that serves particularly uninsured folks. The one here in Western North Carolina is in Black Mountain in Buncombe County, which is really a real resource and asset for Buncombe County. And my role with Buncombe County, besides the work at ADAC, my role with Buncombe County is to be like an addiction expert, a consultant for the county to help lead some of the strategies and decisions around how the county responds to this overdose epidemic. How do we reduce the risk, make our communities healthier, and particularly how do we manage the opioid settlement funding that many or all the counties in the state received to better serve the community.
Cool. Well, thank you for bringing your experience to the county, and thank you for taking some time to talk with us today. Let's go ahead and just dive into some questions. Sort of foundational question, will you just tell us what opioids are and what is the difference between legal and illegal?
Yep, great question. So opioids are mostly, or originally were naturally derived chemicals, medications, drugs that came from the poppy seed. And so the oldest kind of version of an opioid is opium. Has been around, for thousands of years. Uses medicine as an analgesic for a variety of medical issues in a variety of civilizations. Maybe a few hundred years ago, humans were able to derive morphine from opium, and which is one of many opioids present in the poppy plant. And I'm getting my years wrong, but maybe around 200 years ago or 180 years ago was the invention of the intravenous needle. And so that really changed things because that allowed for these medications not only to be used in more invasive ways or more concentrated ways, but allowed for concentrations that could prove lethal. And so since then, a variety of compounds have been derived from sort of those natural compounds, including heroin, which is also derived from the poppy plant. And there's also been a various progression of various synthetic opioids. So those are not directly from the poppy plant, but they're made in labs. And so oxycodone is a pretty common synthetic opioid, as well as methadone. So opioids, whether natural or these synthetic opioids, all kind of work the same for the most part. They work on opioid receptors, and really all hormones and chemicals that affect kind of many living beings, certainly animals and mammals, work in this kind of method of a drug or a hormone working on a receptor. And so there are opioid receptors of a variety of kinds in humans and also in other animals that these opioids work on. I think of it, or I often describe it as a lock and key kind of concept where you might have a lock, which is the opioid receptor, and you have a variety of types of keys that work in various ways to open that lock partway or fully and drive an effect. And so opioids, for the most part, cause pain relief at a certain dose, can cause euphoria at a higher dose, and can cause respiratory depression, meaning people stop breathing at the highest dose. This is the effect, whether that is a legal or illegal opioid. I went to a great presentation actually this past weekend at addiction conference held here in Buncombe County, hosted by the Governors Institute. And there was a researcher that kind of went through the hundreds of years history of drug regulation in the United States. And I was surprised personally because I knew that a lot of these products, morphine, were present in medications, especially before pharmaceutical kind of regulation, maybe 100 years ago. But she had a picture of a housewife's heroin, like literally said heroin that cures all ails. Wow. And so these were medications used, more or less safely. There were definitely risks, but you didn't see a lot of overdose in those days because the concentrations were so low. But these compounds have been, whether legal or illegal, different categories through many years. The designation, whether something's scheduled as a illegal, worthy of a felony, or legal prescribed by me as a doctor, that's man-made. Those are man-made distinctions. But the effects of those medications on the human body are all the same, save for the potency. And so certain drugs, we all hopefully will be talking about fentanyl. Fentanyl much more potent per milligram per gram than something like heroin or morphine.
Interesting. So we've sort of talked about the substance now. Let's talk about the next step and the sort of human interaction with it and just discuss addiction. Can you define addiction for us?
Yeah, so addiction, the word we use in the medical world is substance use disorder. And so, and the definition is pretty important. It's sort of changed over the years, but the current definition in the medical community is a use disorder needs one of three categories, or two of three categories, and often multiple symptoms in each of the categories. One category, which we're pretty familiar with, is tolerance and dependence. And so those are what we call physiologic effects of an opioid or any drug. So tolerance is, the more you use, the more your body gets used to the compound and the more you need. And so a classic example is somebody who can drink 2 cups of coffee and take a nap, right? I personally am very sensitive to caffeine because I don't drink much. So if I drink a little tiny bit of coffee, I will get really awake and not sleep for 3 days. But some folks can drink, lots of coffee and, sort of just take a nap. That's a reflection of tolerance. Dependence and withdrawal is sort of the other side of that, where if someone stopped drinking their coffee when they're used to drinking multiple cups a day and they stop, they might develop headaches, irritability, difficulty concentrating. That's withdrawal effects, and that will probably last for some days. We see this effect from a variety of medications, depression medications. We see it from nicotine, from alcohol, and so we see this from opioids. That alone doesn't make addiction. So someone might say, I'm addicted to coffee, but that's not the medical kind of way of thinking of addiction, because you usually need something from the other two categories. The other two categories are uncontrolled use, so someone who's unable to decrease how much they're using, someone who's unable to decrease how much they're spending, how much time they're spending, how much energy they spend seeking that drug or that medication. And the third category is negative consequences of use, or use despite negative consequences. So those could be changes to your social situation, relationships with your loved ones, physical health issues, employment issues, a variety of things. So you really need those two in addition to the physiologic effects. So coffee, for the most part, people can quit if they want to or cut back if they really had to. Most people aren't having health issues or social issues, so maybe some do, but whereas opioids clearly cause a lot of those harms.
Got you. So it's not just physical, it needs to have that sort of negative impact on one's life to be defined as, clinically defined as addiction, is that correct?
Correct.
Okay.
Yep, as a use disorder. And I will say, designating something as an illegal opioid sort of influences that, right? So if, Nick, you're my patient, I'm prescribing you morphine for a medical condition of pain, well, I'm controlling it so you're not having uncontrolled use because I'm sort of monitoring that. And, the idea is the benefits outweigh the risks. Your pain relief from your cancer that you might have that's causing pain is worth the risks that this will cause dependence or slow down your breathing. So having it in a controlled setting where you have those kind of safety mechanisms makes it not a use disorder and just of kind of physiologic dependence.
Got you. Interesting. So we've talked about the substance, we've talked about addiction. Now let's sort of talk about treatment.
Yes.
What treatment options out there work, and how can you find resources to access those options in the county?
Well, and before we answer that, let me just point out, the risks here, if I didn't make it clear enough, of opioids is someone's going to get used to it, right? They develop tolerance, dependence, and so they keep using, and then they overdose. And so the overdose is the real risk, because there's other risks, right? Just opioids in general, whether prescribed or not prescribed, affect your hormones, they affect your immune system. You're more likely to get infections, you're more likely to have falls, car accidents, a lot of things, whether legal or illegal. The highest risk though is overdose. And though that can happen with legal opioids, the bigger risk is with illicit opioids, because if you're buying things from the streets, you don't know what you're getting. Imagine if you were used to drinking a beer every day and just one day instead of beer, it was pure liquor, but it tasted like a beer, you would just overdose. I mean, you drink that beer like you usually do, you would have a big problem because it would be a lot more concentrated alcohol than your body's used to. That's what's happening to people with opioids. And so the risk here is partly that they're using opioids, but the bigger risk is that one time that they use opioids, they might take so much that their body stops breathing. At a high enough dose, opioids cease breathing, the kind of automatic drive for breathing. And so you pass out and you basically suffocate, you stop breathing. So treatment is really getting at how do we get people to stop using opioids in a way that they will stay off opioids. So one problem with that is when someone's used to taking something every day, as we described, they develop a dependence and will have withdrawal symptoms. If anyone has seen opioid withdrawal or witnessed it or experienced it, it is a pretty stark experience, a pretty terrible set of symptoms. People have vomiting and nausea, diarrhea, their skin's crawling, they can't sleep, but they're deathly tired. They're yawning and runny nose, and they call it a flu times a million. It's really a terrible experience, and a number of movies have whether glamorized it or at least depicted it to really show what it looks like. So it's a really awful experience that if someone experiences that withdrawal syndrome, they'll do whatever they can to prevent that from happening. A lot of folks think, oh, if someone's using illicit opioids, they're trying to get high. And I would argue, well, like maybe they are, and so all of us are. Like I'm doing this interview because it sort of makes me feel good to share information, not because I think it's my duty, but because it feels good. People want to feel good. Nevertheless, most people who are using opioids every day are using it because they're trying to stave off withdrawal. Their thermostat is reset. So when they don't use opioids, they feel terrible. When they use opioids, they feel normal. So for me, it was common in the Bronx and in Buncombe County for me to take care of a patient and they used drugs before they could get in the door and come to my appointment. And their hands were steady. They were able to talk to me normally. They weren't like falling over. They were normal on their drugs because their thermostat had reset.
Right.
So part of treatment is addressing that first problem. How do we help people not have withdrawal symptoms, stay steady, feel normal? Because that's what they want to seek. That's what they're seeking, feeling normal. And so treatments, the best, highest level treatment is FDA-approved medications, one being methadone, the other being buprenorphine, is the generic words for those. Treatments that help fill those receptors, or again, the lock and the key kind of concept, fill the lock so that instead of feeling too intoxicated or even getting to the point of respiratory distress, respiratory depression, and stopping breathing, you get enough stimulation of the receptors so you don't feel sick, so you don't go into withdrawal, but you don't get so much stimulation that you're falling over or potentially dying. And so the first step of the methadone and buprenorphine treatment is just filling that receptor so people can be normal. And I gotta tell you, Nick, when I treat patients, the before and after is I don't even have a metaphor for it. It's like day and night.
Right.
There's not so much in medicine. And like I said, I've done HIV and hepatitis C and diabetes and high blood pressure. I've delivered babies. Well, that's hard to compare to that. But I've not seen a medication that works so quickly to change a person's vibe and their complexion and their ability to concentrate and make eye contact.
Wow.
It's really life-changing. So that's sort of the first step of these medications. The second step is how do you help that brain stay stable so that they can pursue other things like counseling, therapy, rebuilding their relationships, rebuilding their lives. And so that medication, those medications taken every day, help keep those receptors happy and stable so that people are not constantly craving the medication or craving the drug, and even after the withdrawal syndrome, seeking the drug, whether through legal means or illegal means. So treatment really centers around that. There is a term called medication-assisted treatment, and that is an old term that we don't even like to use anymore because the medication is the treatment. It's not assisting treatment. It is the treatment when it comes to opioids. This medication has been shown to reduce death, reduce the use of drugs, reduce the acquisition of HIV or hepatitis C, which often happens through injection drug use. It's even been linked to decreased criminal justice involvement, decreased arrest, decreased crime, improved public safety, decreased death. Really is the most important factor here. So the treatment is really, really effective.
You talked about how quick people sort of make a shift, make a transition once starting on the methadone treatment. What is just like an idea of that timeline? Are we talking like days, week, month? What does that look like?
It can vary for different people, particularly in the fentanyl area where a person's opioid tolerance is quite high. So for buprenorphine, it can happen over days.
Wow.
Which we'll probably get to in your questions, our post-overdose response team here in our EMS department has been for years now treating people with buprenorphine, one of the 2 FDA-approved medications, treating people in the community, in the field after an overdose. So they revive from an overdose, they start on the buprenorphine. They're getting reports that like the next day the person's a whole new person, right?
Wow.
I mean, clearly they just had a near-death experience. That's sort of the one end of the spectrum. But getting within a day to, like cancer treatments, diabetes treatments don't even work that well, where within a day or two, someone's just like a whole new person and able to function a lot better and at much less risk of overdose and continued substance use. Methadone's a little different. Methadone, you have to increase the dose over time, really over weeks and weeks. So it might take some time for that to kind of stabilize a person's substance use and mental health and all those things. But we do see those changes happen over that time, and it's really miraculous.
Amazing. Okay, so we've talked about substance, addiction, we've talked some on treatment. Let's sort of look at what this misuse of opioids is doing from kind of like a more zoomed out picture and how it's affecting our communities.
Yeah, I mean, I was a teen in the 90s, and I felt, like watching TV and things like that, you would think HIV is sort of a generational thing, right? That's something I grew up with, of just like human beings' relationship with sex and intimacy really changed because of HIV. Wearing gloves in hospitals, like our relationship with bodily fluids changed. That was a change in, this is me kind of getting really creative here, really change in our species of how we relate with our environment, relate with each other. The death rate from HIV was really high and just had a really huge public health impact that's still being felt generations later across the world. My feeling is that substance use and addiction and overdose is this current generation's like big problem that's going to affect them and define our relationships with each other and our communities and in this case with what it means to feel good and feel happy. What does that all mean? And really reflects one of the biggest ways of dying in America. So for many years in a row, save for COVID, because some of that data is still being parsed out, but for many years before the pandemic and until now, the number one way of dying in America for people under 50 was overdose.
Wow.
And unfortunately, the number two reason was suicide, which and a lot of the reasons and causes for those two problems are linked, has to do with poverty and lack of resources in a community, lack of employment and housing and opportunity and mental health treatment. And so those two problems, but overdose being number one, again, people in a country as wealthy as ours with so many resources should not be dying from something that's preventable, that's treatable, and yet that's number one cause of death for working age people at the prime of their life with families to take care of, et cetera. So we have not peaked yet. I feel like for a number of years, people are like, oh, this is the peak, and then the next year, it's still not the peak. And so I've not been saying we peaked, right? It could be worse next year, but the overdose rates continue to be insanely high. Buncombe County is worse per capita overdose rate than the rest of the state, and our state is worse than the rest of the country for overdose rates and ER visits for overdose. And so despite a lot of amazing work being done by community partners, by the county, there's a fire that's burning really hot. And not only do we need to figure out how to prevent the fire of next time, we really need to put the fire out. And it's a all hands on deck kind of response at the county of how do we get a hold of this.
Wow. Okay, so sort of getting a hold of it, maybe this next question will lead into that. What is naloxone? How do you get it?
Great question. So I did describe the two FDA-approved medications for opioid use disorder. there's, without getting too technical, buprenorphine can be sometimes used for opioid overdose, but let's leave that aside. But those two medications are for treating the addiction. That's often a long-term treatment. It might be forever, just like diabetes and high blood pressure might be treated forever. A lot of people will say opioid use disorder, opioid addiction doesn't have a cure, right? It's something someone lives with, even if it's been doing good for many years. Opioid overdose is a different thing. So opioid overdose is the fact of taking too much of the opioid where it stops your breathing. What this looks like is someone not breathing. If someone's snoring away and they're unconscious, that person's not having an opioid overdose. They might have taken opioids or something else, but they're snoring and just breathing, nice and regular. That's not an overdose. An overdose is someone not breathing. Oftentimes their lips are blue. Oftentimes, if they are breathing, it doesn't sound right. And the average average adult is breathing 12 to 20 times a minute. Someone in an opioid overdose is breathing 1 or 2 times a minute.
Wow.
So sometimes it's hard to tell, but I think it's important to describe what that is. And when someone's not breathing, they're not getting oxygen in their body. They're not getting oxygen to their brain. They're starting to get brain death. Eventually, their heart will stop, and that's the end. Naloxone is the reversal agent. And so back to that concept of the lock and the key. So someone's in an overdose, too many opioids as the keys are on too many locks, and it's flooding the system and things are shutting down. Naloxone comes and knocks all those keys off when you administer naloxone and becomes like a glue in that lock so that the opioid that's still in the bloodstream can't go back to that lock.
Wow.
So it reverses it in that it takes off that opioid and blocks it from coming back. It doesn't last forever. It's about 30 to 60 minutes it's going to work. So usually if you do administer naloxone, somebody still needs to be monitored and maybe sent to the ER, ideally sent to the ER for more monitoring. But it is a life-saving medication. If you think of CPR, which many teachers and first responders and even citizens know how to do, naloxone is in line with CPR. Like everyone should know how to use it. Everyone should have it. Everyone should know where to get it. Because chances are, especially in our day and age, you will come across somebody who needs help in this way. So there are various versions of naloxone, various ways to administer it. It can be given as an injection into the muscle, which is kind of the most common and the oldest way. There's also various formulations that are nasal sprays, and they can be given IV. It's not something you take by mouth. It's not something you eat or drink, especially if you're overdosing, you can't swallow and eat things.
Right.
And so a common way that bystanders and kind of the lay public will use naloxone is the nasal spray. Narcan is sort of the first brand version, but there are various companies now as well as generic versions of this. So it's really easy to use. It's a nasal spray. You just spray it in someone's nose. There's great trainings online. If you just went to your search engine and looked it up, how to use naloxone, you'll find a lot of videos. So it's not something that requires even the level of training of CPR. You really can watch a video and learn a lot from that. And we'll talk about this, right? I think we're going to talk about the county offers a lot of free trainings to individuals as well as community agencies. Where can you get it? There's a lot of ways you can get it. So one is, I think only 6 or 9 months ago, the U.S. approved a over-the-counter version of this. And so you don't need, no questions asked, you don't need insurance, you just need money, but you can go buy this at your participating pharmacy without a prescription. But even before that, our state has been really progressive on this issue, and they had, I think many years ago, signed what's called a standing order, such that you don't need a prescription from your individual doctor. You can go to a pharmacy and ask the pharmacist, can I get some naloxone? And they can dispense it to you as if you had a prescription, because there's just like a prescription for all North Carolinians. You can use your Medicaid card, you can use your insurance card, or you can pay cash to get that. The third way is various agencies across the state and across the county offer this for free. Local harm reduction organizations, local syringe exchange programs, our health department, a lot of clinics all offer this for free. And so if you go, I think a state has a website that shows where in the state you can get free naloxone. And then our county's website, health department website, has information of where you can get free naloxone, including here, or not here, but down the street at 40 Cox at the health department.
Cool. Excellent. Let's say that I'm struggling with addiction. I have an appointment to see my doctor. Are there any risks or dangers in disclosing my use and addiction to my doctor?
Yeah, great question. And my first response is, of course not. You should tell your doctor everything. And I'm a doctor. I'm wearing my white coat today. And to be honest, you should tell your dentist and your surgeon and really any of your doctors, because as you can imagine, any clinical decision or medical treatment they offer you is going to be affected by other drugs or substances you're taking. Not to mention, no problem is bigger, I would argue, than an opioid use disorder. So if you came in for a hernia surgery and you have an opioid use disorder, let's leave the hernia alone for now. Let's try to get you help for your opioid use disorder. So I would say, yes, you should disclose this. I mean, there is a risk in that we have like a 70-year history on the war called the war on drugs. And so there are clinicians maybe out there who maybe have a stigmatized view. I think that's very much changed, even compared to 10 or 20 years ago, let alone many decades ago, where most doctors, nurse practitioners, midwives, physicians, assistants understand that this is a medical disorder that can be absolutely treated very successfully with medical treatments. But I will say, if you're uncomfortable with the potential response from your provider, you probably need to seek another provider if that is your problem. And there are many providers who can take good care of you. But I think that's a really rare thing. And I will say that if you're disclosing you have a use disorder, no one's going to send you to the police. Having a use disorder is not an illegal thing. In fact, it's considered a disability. The Office of Civil Rights at our Department of Justice in the federal government has made it very clear having a use disorder is just like having cancer or diabetes or some other medical condition. This is a disability that requires accommodations by law. So for instance, if you have a use disorder and you need to get treatment, your employer has to allow you to go get treatment, has to support that, cannot fire you just because you have a use disorder. And they have to give you accommodations, just as if you needed a wheelchair, you needed accommodations, with a ramp to get into the building.
Right.
Same thing. So this is a protected class. Using drugs is not protected. Let me just be clear. You don't want to go and bring your doctor your drugs, but disclosing you have a use disorder, seeking help, that is something that is protected and should be done because that is life-saving.
Right. So there's some security in having a candid conversation if you feel like you're receiving care that is comfortable and open to it then.
Absolutely.
That's reassuring.
I would put a plug there for folks who are maybe uncomfortable with the medical system or even estranged from it. A lot of people that struggle with addiction are living on the margins of society, struggle with housing. Not a lot, but some at least. There's great services through peer support organizations and harm reduction organizations. Those are folks who are in the community going to the streets to kind of engage with people and kind of talk to them about what their options are to be healthier. So a lot of these folks, they don't get the best treatment in the ER. They don't get the best treatment from the system. And so sometimes having these lower levels of low barrier care are the ways to engage folks who are really deep in their addiction or having other social issues.
Cool. That's excellent work and resource. Looking now through the lens of the youth in our community, what specific dangers might they be facing? One thing that's noted here is the risk of contaminated pills. I just wanted to get your thoughts on that.
Yeah, and a paper came out in the past year in the New England Journal about the rates of opioid use disorder. Again, that's the addiction to opioids. It's actually been going down amongst adolescents over the past 10 years. At the same time, the rates of overdose have gone up. What does that mean? That means the youth, teens, are not using opioids on purpose as much as they used to, but they're still dying at higher rates. And that's reflecting a couple of things. One is contamination of drugs, such as, like a lot of youth experiment, right? And it might have been some years ago that you use your dad or your grandpa's beer or liquor or smoke a little weed or something like that. I think the youth nowadays, it's a much more digitally connected generation, and so they have access to things that at least I didn't have access to when I was a teen, and so they're able to buy substances online that they might think are Xanax or Adderall or some other drug, and then it's contaminated with an opioid. And I did describe earlier the idea of tolerance, right? So you're using something every day, and then you get dependent on it. For folks who have not used something every day, they're much more sensitive, just like I am to coffee.
Sure.
And so if someone is taking a pill that they think is Adderall, and they want to study, they're in college, they want to study, and they got on TikTok and found somebody that's going to sell them an Adderall and has even a little bit of an opioid in it, that could be a life or death situation. And we've seen that across the country, though the data is still kind of being worked out. The other way is someone who is using opioids, But again, there's contamination. There's things in it, just like for an adult, that they didn't expect, and then they overdose from that. And so this is a new risk for youth. It's not so much like we need to give them methadone or buprenorphine for their treatments. You can't really do that if someone doesn't have a use disorder. It doesn't make sense. But we do, I think, need to talk to our teens and maybe even younger about the dangers of these contaminated pills, the dangers of buying things from people you don't know particularly, and the uses of naloxone and other harm. I mean, one thing about naloxone is you can't use it on your own, right? And so a lot of these deaths for adults and teens, someone alone using drugs by themselves, getting ready to study, taking this Adderall, and there's no one there to help you when you stop breathing. And so there's a number of ways to, we can teach youth how to reduce that risk.
Got you. Somebody who's buying pills from nefarious sources, is there a recommendation to do any sort of testing of substance? What does that look like? Can you touch on that?
So this is sort of a new concept, I guess, to be talking about in this setting and to have as a resource in, for instance, a health department. But it's really a intervention that's been around for decades, particularly around like festivals and raves maybe a few decades ago, where people either selling drugs or using drugs would be able to test their drugs for potency or for contamination. So this concept isn't new. It's just become all the more important now that overdose is such a huge problem, as opposed to just wanting to know what's in your drugs and that you can have a good time with your drugs. And so there are ways to test at the point of care, such meaning you don't need a special license, you don't need to bring it into a special place. They're basically strips that you can use, that you can do a few steps to take a little piece of, let's say, a pill or of the powder out of a bag and test it for the presence of fentanyl, the presence of things like xylazine, a new contaminant we're seeing that's causing a lot of trouble in the community that uses drugs. So those resources are there. A lot of the folks that give naloxone, like harm reduction organizations, our county's health department, can provide this for free as well. And then these are legal things you can buy, so you can buy it online. There's a lot of companies that'll sell you these strips. I think it might be $1 or $2 per strip, so they're pretty cheap. When I think about this for youth, because this is a pretty, Nick, you're getting to some really the new of the new of, just the couple of years of me doing this work in Buncombe County, things have changed just in this few years. So when I think of this for youth, I'm not sure, I'm a parent myself. I don't have teenagers, I have younger kids, but I don't know. I can't make heads or tails of what a parent would think about, like, I'm going to get strips for testing for my kids. But it is the way to know what's in your drug, particularly if you think you're buying an Adderall. I mean, that should not have fentanyl, and so that's a really useful utility of it. But definitely for people who are regularly using drugs, this is a great modality to kind of figure out what's in their substances. There's also some ways to have your drugs sent out for more advanced testing for the variety of contaminants that now exist in the drug supply. And so our health department, and again, those harm reduction organizations, Steady Collective and WinCap and Holler Harm in Buncombe County, all active, they collaborate to send samples to UNC in Chapel Hill for the UNC drug checking lab so that they can get results of, like, what else is in this drug.
Interesting. Cool. It's excellent to know that those resources are there. Next question on my list, we've touched on this a little bit. I just wanted to see if you had anything more to add. You illustrated sort of what withdrawal looks like, and I felt like it was a pretty appropriate representation. I didn't know if there was anything else you wanted to touch on that.
Yeah, maybe nothing more with withdrawal, but like I think there's this idea, particularly in older versions of addiction treatment, and which often relied on abstinence, of if you get the withdrawal is the bad part, and certainly it's bad, and you get someone through that period of time, and now they're good. Now they just need to not use drugs, and that's not the way the brain works. So using drugs, I guess is the best metaphor I can think of. It's sort of like a lot of other learned behaviors, right? Like if you brush your teeth with your right hand, one day you try to do it with your left, it's not going to work that well. It's not going to be coordinated, or maybe throwing a baseball or something like that. Using drugs, the more you use it, it reinforces that behavior such that if you have a good day, it's a good day to use drugs. If you're having a bad day, it's a good day to use drugs. You get into the habit of it. So even after the withdrawal period, you have this thing called cravings, which persists for a long time on good days and bad days. And that's why people return to use despite, kind of working on it, despite a desire to stop using drugs. And that's because those brain pathways are reinforced. And so part of addiction treatment, besides stabilizing the brain and preventing the overdose with the medications, is creating new pathways, new ways to deal with a good day, new ways to deal with a bad day. And so I guess I wouldn't say more about withdrawal, but the cravings are sort of the second half of that. And it's important to consider that you need treatments for both and that the medications work for both.
Mm-hmm. And treatment is sort of like an ongoing, it's not like a one and done thing. You have to continue down that path.
Yeah,
It's like a daily decision almost.
Yeah, I mean, and I would say most people that take medication are super happy on it. You know, it's not like, oh man, I got to take my blood pressure medicine or inject my insulin. I mean, you know, getting somebody to continue their insulin is also very hard because it, you know, it hurts and it makes people feel kind of different ways. Buprenorphine really very much doesn't have side effects. Maybe a little constipation, but not on par with fentanyl, because fentanyl and opioids cause constipation.
Right.
But otherwise, people feel great on it. Depression improves, concentration, mood, all these kind of things improve. It even reduces cravings for alcohol and methamphetamine in some studies. So most people don't have trouble continuing on it. Often it's these stigmatized misconceptions. You're replacing one drug for another. Not true, right? Like this is something that's life-saving. It's like saying insulin's replacing one drug for another. I guess you could say insulin is replacing your insulin that your pancreas isn't making, but this is life-changing, right? Life-saving. So yeah, people will often be on it for a while. Research shows really at least 6 to 12 months is required to really change overdose outcomes. But a lot of studies are showing the longer you're on it, as long as it's benefiting you, the better it is for you.
Okay.
It's a little bit like a seatbelt, right? So let's say I'm driving 100 miles and I wear a seatbelt for 50 of those miles. I'm definitely going to be less likely to die if I get in a car crash through the 100 miles because at least at 50 I'm protected. But it's probably better if I wore it the whole time, but still better than to wear it for 50 miles than 0 miles.
Sure.
These medications are like that. As long as you're getting a benefit, you should be on it. And the side effects are very rare, particularly with buprenorphine.
Got you. Let's see here. Let's touch on why is it hard for people to get help or ask for help?
Yeah.
And what are your thoughts on that?
Yeah, and this is my life's work nowadays because it's not very common that we have like, I don't know, like I don't want to get sci-fi, but we have this precious nectar from the gods, like this precious way to save lives and help people. And why aren't we just doing a lot more of this? So there's a list of barriers. I mean, there's like enormous research. And again, this is like what I'm an expert in is what are the barriers and how can we get over that? I would put at the top of that list, paying for treatment. That's the maybe tie for number one. So I'll say that as the first number one, because in North Carolina, we only recently expanded Medicaid. Despite that expansion, a whole lot of people, particularly childless adults, are going to have trouble getting Medicaid coverage, or I'm sorry, will not get Medicaid coverage. You know, luckily there are subsidies for getting Obamacare, but still, there's difficulties in engaging in these systems. So a lot of people can't get a doctor, can't pay for their doctor's treatment or their nurse practitioner's treatment, can't pay for the medication. And I got to tell you, usually the fentanyl dealers come in your house or like is right next door, or it's really easy to get that. We have a society where it's a lot easier to get the dangerous thing than to get the life-saving thing. And that's backwards, right? I mean, duh, when you say it out loud, duh. So insurance coverage and transportation and having a provider in your community. I mean, Buncombe, we are rich in providers. We have a lot of methadone clinics. You go a few counties west, it's a lot harder. And so it's still a problem here, but worse in a lot of parts of the country. So I would say that's number one, how to pay for treatment, engage in treatment. The other half of that, or part two of that, is stigma, which I referred to earlier. We've all learned, me included, and you know, I got very little education around this in medical school. They taught me about porphyria and the rarest of cancers and all these rare things. Much more so in my pathology class than addiction, which again, number one cause of death for people under 50. Wow. Same with residencies. This is starting to change with the modern students, but we have a stigma where we never thought of this as a medical problem. We often define it as a behavioral problem. When people die, it's, you know, I guess everything is a behavioral problem. Like, you know, having diabetes is a behavioral problem. If you change your behavior, you might change your diabetes, but it's a medical problem. That's the way I'll define it. And so we have a stigma of like, this is something that belongs way over here in specialty treatments. In communities, it's something we shouldn't talk about. It's embarrassing. Really, shouldn't those people go to jail? It's a crime. I mean, how often do we hear a medical problem is criminalized, right? Like it's illegal to engage in your medical problem. Imagine if it was illegal for diabetics to buy a Coca-Cola, right? I mean, maybe that's a treatment for diabetes. You have less diabetes. You probably won't. What you'll have is a black market for sugar, and you'd have a lot of people hiding in the shadows, drinking soda and dying, from their untreated diabetes. This is what we have for opioid use disorder and all substance use disorders. So the stigma is a really complicated piece because it's tied up with people's beliefs about morality and willpower and choice. These are philosophical things that families and individuals even internally have to deal with. What the research shows is, the research on insurance is clear. Give people Medicaid or give people insurance. Like that's find the money and go apply it in the right place. The stigma is a little more complicated. I mean, this program, these interviews you're graciously asking me, this is part of the stigma, the way we're going to deal with stigma.
Sure.
Having conversations in families, talking about this in our schools, talking about this in our churches. This is the way we're going to combat this, that this is not a failure of willpower. This is not someone just trying to get high. This is a medical problem that someone often from a wisdom tooth extraction or a motor vehicle accident started on opioids, couldn't get off it, and eventually turned to illicit substances because of the systemic pressures on them. So we need to have those conversations. Maybe I'll stop there. Those are really the top two. I mean, you go and break it down into, transportation, access to treatment. If you're Spanish speaking, if you speak a second language, do you have a provider that can treat you? In the Black and brown communities, having a provider that looks like you has been associated with better outcomes. It is very rare in Buncombe County to have a non-white buprenorphine prescriber. There are some, and it's grown, and I'm really happy that Minnie Jones now has a new CMO, but that's another aspect, especially as we see the rates of opioid overdose very much accelerating in Black and brown communities.
Got you. Awesome. So empowering these individuals that are powerless through discussion, through sort of destigmatization, I think is a really important, valuable thing.
There's
hiding it is not the answer.
No, I'm struggling with a metaphor of we have the answers. I can tell you the four things, and we've already talked about naloxone, buprenorphine, methadone, the FDA-approved medications, peer support, which we haven't really touched on, but that's people with lived experience of going through this problem and achieving recovery, engaging with this population, and then other harm reduction measures like the strips and naloxone and things like that, syringe exchange. Those are the four pillars. We know this works. There's decades of research on a lot of these things showing how it reduces overdose, reduces addiction, reduces criminal justice issues, reduces mental health crises. We talk about the downtown area and all the struggles there. If we had proper access to all these four pillars, you'd see a great change in the community safety perceptions of our downtown citizens and businesses. So it's kind of amazing. We have these answers. We just need sort of the political will to deploy this. The county is a leader in this. I'm not just saying this because I'm, got a little county badge on. The county's really led this. A lot of counties have been doing great work. This is still a kind of a problem of do we have enough insurance coverage for all Americans?
Right.
Do we have enough providers for all Americans? How do we deal with the stigma for all communities in America? This is something where the work is still yet to be done.
Awesome. And speaking to that work, are there any upcoming community events where people can learn more? And how does one arrange for a free naloxone training?
Yeah, great questions. So we just did, a couple of weeks ago, my time is blurred because of my children. A couple of weeks ago, we did a great event, Opioids in the Black community, here at 40 Cucks at the Health Department building, which is great. And we hope to do more events like that kind of focus on the Black community and other communities, LGBTQ. We're planning one for the Spanish-speaking community of Buncombe County. So those are some upcoming events. And so if you stay tuned to the county website, you'll see when those dates are settled. Hopefully this summer we'll have that event. And then there's a number of ways if you're a restaurant or a bar or some kind of organization, if you're a construction company, whatever it is, there's a fair amount of opioid overdose in the workplace. So employers, community groups, churches, mosques, synagogues can all arrange for free naloxone trainings, and oftentimes they'll come with free naloxone to dispense to your to your community members. You can get that through the health department. So if you check out our health department's website, which I'm sure we'll post with this video, you can get information about that. They have a monthly kind of walk-in naloxone training at the health department, so individuals can get that. Our paramedic team associated with our EMS department can come do a training for any group. And our syringe program, also housed in our health department, can do free naloxone training.
Awesome. Excellent resources. Today we've talked primarily about opioid addiction.
Yep.
Can you touch on other substances and treatment options?
Yeah, so it gets a little more complicated. So opioids definitely lead the way in causing the overdose death, as I described, and stopping breathing. We are seeing a lot more of what they call polysubstance use. And so that's people, which it feels new, but it's been real, like I make this kind of offhand comment. It's like the Red Bull and vodka concept. People have been mixing substances for millennia, right? For desired effects of those or to mitigate the side effects of one substance using another. So it's not new, but really the rise in overdose has also mirrored the rise of methamphetamine use in rural areas of America and cocaine use in urban areas. In Buncombe, we see a little bit of a mix, more methamphetamine. Both of those are stimulants. We used to call them uppers, I guess, when I was a kid. There's research to show that actually decreases the risk of overdose from opioids. Nevertheless, it has a lot of its own harms. Unfortunately, there's no FDA-approved, silver bullet like there is for opioid addiction that there is for stimulant use addiction, stimulant use disorder. There are treatments; those are actually a lot more behavioral. Cognitive behavioral therapy, talk therapy, different things like that can help people reduce or stop using. Alcohol use disorder also still a very big cause of death and liver disease and harm and motor vehicle accidents, domestic violence. You have it. Still a big problem. Very much a legal substance. Very much every commercial during every football game full of this. Yep. I more power to the breweries in our communities, but this has a lot of harm. There are excellent treatments. In fact, some of the treatments for opioid use disorder help with alcohol use disorder, can decrease the cravings and decrease the use. So those are things definitely talk to your doctor about or your clinical provider for more help around those issues.
Awesome. Thanks for touching on that. And I wanted to ask one other question. We've talked a lot about through the lens of the individual who is addicted, the addict.
And Nick, can I just interrupt? We try not to use the word addict.
Thank you.
And
sorry.
And no need to be sorry because I've said the wrong words many times in many contexts. But I think it's a great point in that we have to change our language because that matches the stigma. It seems a little soft, but it's real in that using words like that makes a person feel like they're defined by their medical problem.
Sure.
And I even thought to myself I shouldn't use the word diabetic because that's it should be a person with diabetes. You think this is just semantics, so we're just being soft here. The truth is there's been studies where a doctor, like me, reads a patient history. Both of them are identical, but the only change is the language. So this one might say addict with a dirty urine screen and a junkie and all this. And the other one says the more medically appropriate language. The decision-making actually changed in the simulation where the doctor's reading the nice thing. They had a better prognosis. They had more empathy for their patients. And so I hate to interrupt you, but I'm also glad to interrupt you because I think we have to model it, especially for our audience at home, to model that the words matter that we use.
Cool. Thank you for that clarifier. Nope.
Yeah.
So helping these individuals oftentimes are friends and family.
Yeah.
And what they're journeying through is a challenge to watch and experience from that perspective as well. I was wondering if you just had any words of advice for friends and family that are supporting along this way.
This is really challenging. It's really challenging. I would say number one thing is have naloxone in your home and talk openly with your loved one about their use as much as they're comfortable. Sometimes that's a trigger for that person.
Sure.
Because there's a lot of trauma built into families. Whether it's on purpose or not. But I will say people that use drugs alone are more likely to die. And I've certainly had, I've had adolescent or youngish patients who they'll crack the door to their bedroom when they use. And that was like the kind of silent way that the mom and the child communicate of I'm cracking the door so you can kind of have an eye on me. I mean, that's the kind of level we're at. This is the crisis of America, and this is a family that was in Buncombe County. So I think having naloxone and having the kind of first level harm reduction and safety approach to that addiction is the first step if you want to see your loved one the next day, right? I mean, you can't work on the addiction until you prevent them from dying. Getting someone to accept addiction care is a lot more complicated.
Sure.
I think a family member's job is to show love. It's hard for me to comment on whether paying for everything and letting letting the addiction happen is love, but also throwing out your loved one or shutting the door on them maybe isn't love. That's a hard thing to say. I'd say if a family member is dealing with this, they probably might need their own counseling just to deal with
Yes.
their problem. There's group support, Al-Anon and kind of groups like that that help family members to deal with their own struggles of having a family member with an addiction. I'd say that's probably the second step for someone struggling like this. And once you find that community, you can kind of figure out ways of how to help your loved one maybe get into care or be safer. But I don't think it's a one size fits all. So I don't want to say like,
Sure.
oh yeah, like kick them out. Don't do that. But also don't let them, drain your bank account either. That's probably not healthy for anyone.
Right.
So it's a pretty challenging situation for families.
Got you. Well, thank you for giving some
Yeah.
notes from that perspective.
Sure.
We've sort of made it through our questions. I'm wondering if there's anything we didn't touch on today that might be important to this conversation.
Yeah, I mean, some of the programs in Buncombe County, and there's been some local news articles about this, so if folks are interested, they can kind of look that up. But the county's been leading in some really innovative ways for helping the folks who are most at risk in our communities. And it's the same story kind of in other parts of the country. We have a problem that's been criminalized and continues to be criminalized. Our sheriff has been awesome at saying we can't arrest our way out of this problem. Nevertheless, a lot of people with substance use are on the fringes of kind of the social world and sometimes will have criminal activity and end up in criminal justice involvement. And so I would just like to highlight, like, there's a disproportionate incarceration of people of color particularly, but of just people with substance use. There's a lot of mental illness and substance use in jails and prisons. And though I would say jail and prison is really not healthy for anyone, even if we think they deserve that setting, providing treatment is a real way to start changing the story on this. And so that's something we're doing in Buncombe County for many years. Our sheriff is really progressive on this. Our EMS department also really progressive and innovative at providing care at the site of overdose or thereafter, since we're having some challenges with our ER and our hospital kind of managing this medical problem. So I think we as a community need to embrace not only combating the stigma, but also like ways to get those 4 pillars of treatment and solutions to people in newer and better ways. It can't be, okay, I'm a doctor, I'm just waiting in my clinic for someone to show up. Like, that's not the answer. We need to go with open hearts and with the solution in hand to make it easier for people to accept treatment than to get fentanyl.
Right. Got you. Well, thank you so much for taking
Yeah.
the time today,
Yeah.
sharing all your knowledge on this subject. It's really important in helping destigmatize this issue. So I really appreciate your time. And I just wanted to say, if you or anyone is battling with addiction, there are resources available to you. Visit buncombecounty.org/safer for more information. Again, that's buncombecounty.org/SAFER. Thanks again for watching.